Hello everyone, welcome to sqadia.com, and in the fourth section of our lecture, Benign Lesions of Ovary, now we will talk about the clinical features and management. In this we will talk about difference between benign and malignant ovarian tumors, how they present, and what's the management of benign and malignant ovarian tumors. First, the difference between benign and malignant tumors. We will talk about the difference between benign and malignant tumors on clinical examination and then on the laparotomy findings. So on the clinical examination, the difference between benign and malignant, benign is usually unilateral, so they are only present on one side, but the malignant is bilateral, or they are present mostly on the both sides. Benign are mobile, they are easily movable when we try to move them side to side or up and down, but the malignant are usually fixed, they are not mobile. Benign are cystic, malignant are solid. The surface on the clinical examination of benign lesions or benign tumors are usually smooth, but malignant they are irregular. Ascites or presence of fluid along with the tumor in benign, it's absent, but ascites is common in the malignant tumor. Growth is slow in benign, it's rapid in malignant, and the age of the patient is usually the benign tumors are in the younger age group and malignant are in the old age. Nodules are present in pouch of Douglas, is usually absent in benign, and they are present in the malignant tumors. So very common differences between the benign and malignant on the clinical examination. Soft and smooth in benign, rough in malignant. Movable in benign, not fixed in malignant. Unilateral in benign, bilateral in malignant. Ascites absent in benign, present in malignant. Young age in benign, old age in malignant. Nodules absent in benign, present in malignant. So these are some common differentiating points on clinical examination of benign and malignant tumors. Then in laparotomy findings, once the laparotomy is opening of the abdomen and then direct visualization on the laparotomy, the findings are again ascites is absent in the benign, it's present, and when we see the ascites through the laparotomy, it's hemorrhagic or blood is present in the ascitic fluid. Then there is exophytic growth on cervix, surface of the ovary, usually absent and present in the malignant growth. Adhesions are absent, present in malignancy. Cut section of benign tumor, there is cystic and is solid and hemorrhagic in malignant. And there are peritoneal nodules present in malignant and absent in the benign tumors or growth. So these are some common differences between benign and malignant tumors of the ovary, with clinical examination and on laparotomy findings. Then difference between between benign and malignant tumor on ultrasonography. On ultrasonography, benign usually are cystic areas with thick or multiple linear echoes present, and on color transvaginal sonography, usually there is vascular branching and flow in the benign lesion. In the malignant, usually cystic areas with irregular heterogeneous solid part, more than 50% total tumor volume. So again, in malignant, there is irregular cystic with the solid part present, and there is neovascularization present in the malignant tumors on ultrasonography. Then struma ovarii and stromal carcinoma. These are the struma ovarii is a type of monogonal type of teratomas. These are the teratomas in which the mature thyroid cells are present. Teratomas are again like a dermoid cyst. Teratomas are the growths with different type of tissues present. So in this stroma ovarii, we have the tissues of the mature thyroid cells are present. This is the picture of the patient with the huge tumor. The abdomen is huge, and how the patient present with the benign tumor. Usually the signs are their patient is very cachectic, weak, very weak. It's their patient present with pitting edema as a result of ascites, huge abdomen with ascites present, and pitting edema is when we press on the area, usually there is a dimple formation, and edema is very common, pitting edema in patient with ascites or fluid in the body. Usually it occupies the lower abdomen. And then the management of benign ovarian tumor is surgery. In young patients, usually the ovarian cystectomy is done. If the patient is young and they want to have a pregnancy or they want to conceive, it's better to do the cystectomy in which the cyst is removed. Then if in some cases ovariotomy or removal or opening of the ovary is done. Then we have in Paris women around 40 years of the age, usually total hysterectomy with bilateral salpingo-oophorectomy. So depending on the age, if the patient is completed the family and they don't want any more children, usually hysterectomy in which the uterus is removed along with removal of tubes and ovaries on both sides. In between the two extreme ages, usually the again individualization. If the patient is between the two extremes, again depends on the individual patient. If the patient is completed the family, then depending on the patient's choice, hysterectomy or bilateral salpingo-oophorectomy is done. If the patient needs to have children, then usually cystectomy is preferred. It saves the ovary and the cyst is removed. Next, for guidelines for surgery in benign tumor, first is incision. Usually, what type of incision is usually performed is vertical paramedian. Vertical incision is done. It's usually big enough to remove the cyst intact. And the content of the cyst may be mucinous. It can be sebaceous, infective, or malignant. So, or the incision can be longitudinal, in which there is exposure to upper abdomen. So, two types of incisions are given for the removal of the cyst. One is vertical incision, and then the longitudinal incision. Vertical incisions are usually big enough to remove the cyst intact, and different types of fluids are present in the cyst that are removed. So longitudinal incision or paramedian vertical incision is given. Then we inspect what's the type of fluid, peritoneal fluid present, whether it's clear, straw colored, whether it's hemorrhagic or infective, and then the cytological examination is performed to find out what are if it's benign or malignant. Then to deliver the tumor, which can be benign or malignant. Then to inspect and to palpate, we do palpation or inspection of the other ovary, pelvic organs, omentum, liver, diaphragm, and aortic or para-aortic lymph nodes are inspected. Then to proceed for definitive surgery. Then once all these guidelines are followed in what type of incision is given, and then on inspection what type of fluid is present, whether it's benign or malignant, and then we also examine the other structures present once the surgery is performed, and then we go for the definitive surgery. And then tumor is removed after all these measures. So that was all about the management of the benign ovarian tumors, how the surgery is performed, and what's the different prerequisite for the surgical procedure. Thank you for watching sqadia.com.